In total anomalous pulmonary venous return, all pulmonary veins drain into the systemic venous circulation rather than the left atrium. Because there is no direct connection between the pulmonary veins and the left atrium, oxygenated blood cannot reach the systemic side without an interatrial communication. An atrial septal defect is therefore obligatory, providing the right-to-left shunt necessary for survival. This defect creates complete mixing of pulmonary and systemic venous blood in the right atrium, with systemic output delivered through the atrial septal defect. The physiology produces cyanosis that varies with the degree of pulmonary venous obstruction. When flow is unobstructed, pulmonary overcirculation leads to heart failure over weeks. When obstructed, pulmonary venous pressure rises acutely, causing severe cyanosis, pulmonary edema, and respiratory distress at birth. This distinction between unobstructed and obstructed TAPVR is critical, as it defines both the urgency of surgical repair and the stability of initial presentation. TAPVR is classified by where the pulmonary veins drain. In the supracardiac type, which accounts for about 45% of cases, pulmonary veins connect above the heart, usually to the superior vena cava or innominate vein. In the cardiac type, about 1/4 of cases, the pulmonary veins return to the coronary sinus or directly into the right atrium. The infracardiac type, also about 1/4, drains below the diaphragm into the portal vein or inferior vena cava. This variant is most likely to be obstructed because blood must pass through abdominal venous pathways before reaching the heart. The mixed type, about 5%, combines more than one drainage pattern. The clinical relevance of this classification lies in predicting presentation and surgical complexity. Obstruction is common in infracardiac connections and leads to emergent symptoms. Supracardiac and cardiac types are more likely to be unobstructed and present later with heart failure. Accurate identification of the drainage site is therefore essential for surgical planning and risk assessment. In TAPVR, all pulmonary venous blood returns to the right atrium rather than the left. As a result, both systemic and pulmonary venous return are completely mixed in the right atrium. Systemic output is possible only because of an interatrial communication, usually an atrial septal defect, that allows blood to cross into the left atrium. The degree of systemic oxygenation depends on how effectively this shunt permits mixing. When pulmonary venous return is unobstructed, the physiology produces volume overload of the right atrium and right ventricle. Excessive pulmonary blood flow leads to congestive heart failure over weeks to months, with cyanosis often mild. In contrast, when venous drainage is obstructed, most commonly in infracardiac TAPVR, pulmonary venous pressure rises dramatically. Pulmonary edema and severe cyanosis develop from birth, and systemic oxygen delivery plummets. Fixed splitting of the second heart sound is a frequent finding due to chronic right-sided volume load. The balance between obstruction and unobstructed flow explains the spectrum of clinical severity and dictates urgency of surgical repair. When TAPVR is unobstructed, infants typically show only mild cyanosis at birth. Because pulmonary venous blood returns freely to the right atrium, pulmonary overcirculation develops, and symptoms of congestive heart failure emerge gradually over the first weeks to months. Tachypnea, poor feeding, and growth failure are common, reflecting the combined burden of increased metabolic demand and limited systemic oxygen delivery. Respiratory symptoms often predominate as pulmonary congestion and interstitial edema worsen with time. On chest radiography, supracardiac TAPVR may display the classic Snowman, or figure of 8 silhouette, created by enlarged vertical and innominate veins above the heart and cardiomegaly below. This imaging clue can be a useful diagnostic anchor, but it is the progressive heart failure picture, rather than sudden collapse, that distinguishes unobstructed from obstructed TAPVR. Recognition is important because these infants may initially appear relatively stable, but are at risk for rapid deterioration if heart failure is not managed and surgical repair delayed. When TAPVR is obstructed, the presentation is dramatically different and represents a true surgical emergency. From birth, infants develop severe cyanosis and profound respiratory distress because pulmonary venous return cannot drain freely into the systemic venous system. Elevated pulmonary venous pressure leads to pulmonary edema, stiff non-compliant lungs, and impaired gas exchange. Oxygen saturation remains critically low despite supplemental oxygen, and acidosis develops rapidly as systemic oxygen delivery fails. These infants may deteriorate within hours, often presenting in extremis with shock. The combination of hypoxemia, respiratory failure, and metabolic acidosis makes immediate recognition vital. Unlike unobstructed TAPVR, where symptoms develop gradually, obstructed drainage demands urgent surgical intervention to establish direct pulmonary venous connection to the left atrium. Without rapid repair, mortality is extremely high. On examination, cyanosis is present in all forms of TAPVR, with severity reflecting the degree of venous obstruction. Fixed splitting of the second heart sound is a consistent finding, caused by chronic right ventricular volume overload. A systolic murmur may be heard along the left sternal border, generated by increased flow across the tricuspid valve. When a patent ductus arteriosus contributes to pulmonary flow, a continuous murmur may also be present. A diastolic rumble can sometimes be appreciated, reflecting augmented tricuspid inflow. The right ventricular impulse is often prominent, and hepatomegaly may be evident if congestive heart failure has developed. These exam features are nonspecific in isolation, but when combined with cyanosis and suggestive imaging, they support the diagnosis and guide the need for confirmatory echocardiography. Accurate definition of venous anatomy is critical in TAPVR, as surgical repair requires precise identification of pulmonary vein drainage. Echocardiography is the first-line tool, but it may be challenging to visualize all venous connections, especially in infracardiac or mixed types. Cardiac catheterization can be used when anatomy remains uncertain, though it is now less common with the availability of advanced imaging. Computed tomography and magnetic resonance imaging provide excellent spatial resolution, allowing clear delineation of venous pathways and their relationship to systemic structures. The essential goal of these studies is to confirm the site of pulmonary venous return, detect obstruction, and define the anatomy for surgical planning. Preoperative imaging must identify whether all pulmonary veins connect to a common confluence, where that confluence drains, and whether any segment is stenotic. Because outcomes depend heavily on complete repair of venous return, comprehensive diagnostic evaluation is mandatory before proceeding to surgery. When TAPVR is obstructed, stabilization is only a bridge to surgery. Immediate operative repair is required, as medical measures cannot relieve the obstruction. Preoperative management focuses on supporting oxygenation and perfusion long enough to reach the operating room. Mechanical ventilation is often necessary to reduce work of breathing and correct hypoxemia. Inotropic support may be needed to maintain systemic output, and metabolic acidosis should be corrected to optimize organ perfusion. Balloon atrial septostomy can sometimes provide temporary improvement by enlarging the interatrial communication and enhancing systemic mixing, but its benefit is limited because the true problem is pulmonary venous obstruction. Importantly, attempts at prolonged stabilization are dangerous, as delay rapidly worsens pulmonary edema and hypoxemia. The principle is clear. Obstructed TAPVR is a surgical emergency, and definitive repair must not be postponed once the diagnosis is made. Definitive repair of TAPVR creates a direct pathway for pulmonary venous return to reach the left atrium. The pulmonary venous confluence is surgically anastomosed to the left atrium, and the atrial septal defect is closed to prevent persistent right-to-left shunting. In obstructed TAPVR, this operation must be performed emergently, often in the neonatal period, to relieve life-threatening pulmonary venous hypertension. In unobstructed TAPVR, surgery is still required within the first year of life to prevent progressive heart failure and pulmonary vascular disease. When performed promptly and completely, surgical outcomes are excellent. The key determinant of success is establishing unobstructed venous flow to the left atrium, since residual narrowing or missed connections can compromise systemic oxygenation. Advances in operative techniques and perioperative care have markedly improved survival, making timely repair both urgent in obstructed cases and highly effective in unobstructed presentations. The most serious complication after TAPVR repair is postoperative pulmonary vein stenosis. This narrowing can be progressive, difficult to treat, and may require repeat interventions. Because pulmonary veins are thin-walled and delicate, even a small degree of scarring or distortion can significantly impede flow and raise pulmonary pressures. Surveillance is essential, as recurrent stenosis can compromise both oxygenation and survival. Other complications include atrial or supraventricular arrhythmias, which may develop from atrial incisions or scarring, and residual obstruction if venous connections were incompletely repaired. Despite these risks, long-term outcomes are excellent when repair is complete and venous stenosis does not develop. Many patients enjoy near-normal growth and functional capacity. The prognosis therefore hinges on vigilant follow-up to detect venous narrowing early and intervene before it leads to irreversible pulmonary vascular disease. Evaluation of a cyanotic newborn requires a structured approach to rapidly separate cardiac from pulmonary causes. The hyperoxia test is a first step. When oxygen saturation fails to improve with 100% inspired oxygen, a structural heart lesion with right-to-left shunt is likely. Pre- and post-ductal saturations are then compared. Differences between the right arm and lower extremities help distinguish transposition physiology, ductal shunting, or coarctation. Fore-extremity blood pressures add further clarity, as gradients suggest obstructive lesions such as coarctation or interrupted arch. Chest radiography provides additional clues. An enlarged cardiac silhouette or abnormal pulmonary vascularity may point toward mixing or obstructive lesions, while specific patterns such as an egg on a string, boot-shaped heart, or snowman configuration narrow the differential. Electrocardiography adds value by identifying chamber enlargement or axis deviations, characteristic of certain lesions, such as left axis deviation in tricuspid atresia. Echocardiography remains the definitive tool, confirming anatomy and guiding emergent interventions. This systematic approach ensures that ductal-dependent and surgically urgent lesions are recognized without delay. Critical decision-making in cyanotic congenital heart disease begins with determining ductal dependency. If systemic or pulmonary blood flow relies on the ductus arteriosus, prostaglandin E1 infusion must be initiated immediately to maintain patency. The second urgent question is whether the infant has obstructed TAPVR, since this requires emergency surgery and cannot be stabilized with medical therapy alone. Another key scenario is the recognition of hypercyanotic, or TET spells. These demand rapid intervention focused on manipulating systemic vascular resistance and relieving infundibular spasm. Once these life-threatening conditions are identified and addressed, attention shifts to stabilization strategies. Balloon atrial septostomy may be required in transposition with restrictive atrial communication to optimize mixing. Careful balance of pulmonary and systemic blood flow is needed, since both undercirculation and overcirculation worsen outcomes. At the same time, systemic perfusion must be supported to prevent shock and end organ injury. These decision points frame the initial hours of care, determining whether an infant survives to reach definitive surgical repair. Emergency stabilization of cyanotic congenital heart disease centers on 3 interventions. Prostaglandin E1 is used whenever ductal patency is essential. This includes transposition, where mixing across the ductus is life-saving, severe tetralogy or pulmonary atresia, where pulmonary blood flow is ductal-dependent, and lesions with ductal-dependent systemic circulation, such as coarctation. Balloon atrial septostomy is indicated when transposition has a restrictive atrial communication, since enlarging the foramen ovale improves mixing. It may also provide temporary benefit in TAPVR, though its effect is limited if venous return is obstructed. The third category is emergency surgery, required immediately for obstructed TAPVR and for severe TET spells, unresponsive to medical therapy. These interventions are not interchangeable. Each targets a specific physiologic problem, whether maintaining ductal patency, creating adequate mixing, or relieving obstruction. Recognizing which pathway applies in the unstable newborn is essential, as delays or missteps can rapidly prove fatal. Surgical timing in cyanotic congenital heart disease depends on both the lesion and the infant's stability. In the neonatal period, transposition requires arterial switch repair within the first weeks before the left ventricle regresses from pumping to a low-resistance circuit. Obstructed TAPVR demands immediate surgery at presentation, as no medical therapy can relieve pulmonary venous obstruction. Severe forms of tetralogy, including pulmonary atresia with ductal-dependent flow, may also require early shunt placement or complete repair. During infancy, definitive repair becomes the focus. Tetralogy is typically repaired between 6 and 12 months, truncus arteriosus between 6 and 12 months to prevent irreversible pulmonary vascular disease, and unobstructed TAPVR within the first year. Tricuspid atresia progresses through staged palliation, with the bidirectional Glenn procedure performed around 4 to 6 months. Each timeline is based on balancing the risks of early surgery with the consequences of delaying intervention, ensuring that repair occurs before pulmonary vascular damage or ventricular dysfunction compromises outcomes. All patients with cyanotic congenital heart disease require lifelong follow-up. Regular cardiology evaluation monitors ventricular function, detects arrhythmias, and assesses the durability of surgical repairs. Endocarditis prophylaxis is advised in many cases due to prosthetic material and altered hemodynamics. Exercise testing helps define safe activity levels, while counseling on contraception and pregnancy planning is crucial since maternal risk is high with residual lesions or ventricular dysfunction. Specific monitoring focuses on late complications. Arrhythmia surveillance is critical, as atrial and ventricular tachyarrhythmias are common after surgery. Imaging and functional studies track ventricular performance, particularly in patients with systemic right ventricles after atrial switch or with single ventricle physiology following Fontan. Valve competence, conduit function, and pulmonary pressures are also followed closely, as deterioration in these areas often signals the need for reintervention. Long-term management therefore extends well beyond the initial repair, aiming to preserve function and quality of life into adulthood. Long-term prognosis varies widely among cyanotic heart lesions. The most favorable outcomes are seen in transposition after arterial switch, in simple tetralogy repairs, and in unobstructed TAPVR repaired early, where survival and functional capacity are excellent. More complex pathways have a different course. Patients with Fontan circulation after tricuspid atresia require lifelong surveillance for arrhythmias, protein, losing enteropathy, and systemic venous hypertension. Those repaired with transannular patches for tetralogy often face progressive pulmonary regurgitation and eventual need for valve replacement. Children with truncus arteriosus require multiple conduit replacements over time as they grow, making repeat operations inevitable. Despite these challenges, early recognition and timely surgery have transformed survival. The critical message is that long-term outcomes are optimized when intervention is performed before pulmonary vascular disease develops and when follow-up remains consistent across childhood and adulthood. Survival into adult life is now expected for most cyanotic lesions, but the course is shaped by the original anatomy and the type of surgical repair performed. Several clinical pearls help distinguish cyanotic congenital heart disease in practice. Infants with so-called pink tet may present primarily with heart failure rather than cyanosis because mild obstruction allows left-to-right shunting and pulmonary overcirculation. Transposition can appear deceptively stable for a few hours, but deterioration occurs rapidly as the ductus closes and mixing is lost. The presentation of TAPVR is defined by whether venous return is obstructed, gradual heart failure in unobstructed cases versus sudden collapse when obstructed. Hypercyanotic or TET spells are true medical emergencies. Immediate recognition and protocol-driven management can be life-saving. Genetic testing should be considered in truncus arteriosus due to the strong link with 22q11.2 deletion. Left axis deviation on electrocardiography is a key diagnostic clue for tricuspid atresia. Classic radiographic patterns also provide anchors: the egg on a string silhouette in transposition, the boot-shaped heart in tetralogy, and the Snowman sign in supracardiac TAPVR. These practical cues allow for rapid bedside differentiation and guide early intervention. The 5 classic cyanotic lesions can be summarized quickly. Transposition of the great arteries is the most common cyanotic lesion in the newborn, survival depending on mixing between circuits, with the egg-on-a-string chest X-ray as a classic sign. Tetralogy of Fallot is the most common cyanotic defect overall, characterized by right ventricular outflow obstruction and risk of hypercyanotic spells, with the boot-shaped heart on radiography. Tricuspid atresia produces single ventricle physiology, requiring staged Fontan palliation to achieve separated circulations. Truncus arteriosus combines a single arterial trunk with early congestive heart failure, necessitating surgical repair in infancy to prevent pulmonary vascular disease. Total anomalous pulmonary venous return has a presentation that depends on obstruction. The supracardiac type produces the Snowman silhouette on X-ray, and unobstructed repair yields excellent outcomes. The unifying principle across these defects is that early recognition, appropriate emergency stabilization, and timely surgical repair determine survival and long-term function. Each lesion has distinguishing clinical, radiographic, and pathophysiologic features that anchor diagnosis and guide management.